You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 16th, 2020. This week, COVID, brain natriuretic peptide, or BNP, polypharmacy, and rethinking inpatient CPR. Beginning with COVID, it is still bad. Cases are increasing in the U.S. A number of colleagues on my EP group speak of increasing numbers of COVID hospitalizations. Three big things happen in COVID science news. First, Eli Lilly's COVID-19 monoclonal antibody is on hold for a potential undisclosed safety issue. I briefly mentioned monoclonal antibodies last week because despite the hype, there are no phase 3 trials whose clinical outcomes. And as I discussed last week, the Bayesian priors on monoclonal antibodies is that these agents will not be game changers for three reasons. A, game changers or magic bullets in medicine are rare. B, upwards of 99% of people infected with this virus will survive, so any therapeutic has a high bar. And C, with the help of scientist and science writer Dr. Hilda Bastian, I found a review article describing 21 monoclonal antibodies that failed in phase 3 trials in the last 5 years. And the second piece of news is that Johnson & Johnson said it was pausing all trials of its experimental COVID-19 vaccine after one participant developed an adverse reaction. There's no word yet on what that adverse reaction was. That is now the second U.S. COVID vaccine trial on pause. The other is the AstraZeneca trial, which was also paused for an adverse reaction. This Oxford-led trial has now resumed everywhere, but in the U.S. it's still on hold. Third, hours before I taped this podcast, the WHO consortium announced results of the Solidarity trial. This was a trial looking at 4 drugs that were tested in 11,000 patients with COVID in 400 hospitals in 30 countries. They tested hydroxychloroquine, lopinavir, remdesivir, and interferon. The primary endpoint of Solidarity was in-hospital mortality. Now, just under 3,000 patients received remdesivir. The control arm was standard of care, not placebo. None of the 4 drugs reduced inpatient deaths. The trial was posted hours ago as a preprint, and the author's final figure in that paper is a meta-analysis of the remdesivir trials. Now, given the large size of Solidarity, the combination of all remdesivir trials show clearly no significant mortality benefit. On Twitter this morning, academic internist Walid Gilad reminded me that the Solidarity trial did not have a placebo control, which was unlike the much smaller American ACTT trial. That is a good point, but I would argue that comparing remdesivir to standard of care is not unreasonable when you use a bias-free endpoint such as death. Now, Professor Martin Landry, the PI of the recovery trial, said on Twitter, "Remember, remdesivir is given by intravenous infusion for 5 to 10 days. It is not cheap. COVID affects millions of people and their families around the world. It is not a rare disease." And Landry said, "We need scalable, affordable, and equitable treatment solutions." I would have to think that the WHO trial ought to seriously reduce the price paid for remdesivir. If the drug has any effect, it is likely to be modest. And think about it, the dollars saved on remdesivir could be used in other more scalable interventions. One that comes immediately to mind is paying workers when they call in sick. Final note on COVID before I go on. On the public health front, I discovered something. I discovered Dr. Stefan Baral He's a public health specialist from Johns Hopkins. His area of focus is disparities in healthcare. Dr. Barral grew up in Sweden, has family who lives now in Sweden, and I'd highly recommend his Twitter feed, and I'll link to it. Why would I recommend it? Because he is brave enough to talk candidly about how our interventions for the virus are increasing the already stark inequalities in healthcare outcomes in the U.S. Next topic is BNP, brain natriuretic peptide, and COVID-19 infection. Now, a group from Stony Brook in New York did a chart review study of about 300 patients admitted with COVID-19 pneumonia early on in the pandemic. This was in March and April. They excluded intubated patients or those that died within 24 hours of admission. Their research question was, in patients without a history of heart failure, does the NT-BNP provide any value in caring for patients with COVID? Thus, they studied the correlation of BNP with all-cause mortality. Now, the median BNP in their study was 156, so they then dichotomized the results into patients with greater than 156 or less than 156, and they found that indeed baseline NT-proBNP was strongly associated with mortality. Adjusting for numerous clinical factors, every log 2 or doubling of the NT-proBNP was associated with a 29% higher risk. The hazard ratio here was significant, with confidence intervals 1.17 to 1.43. Now, chart review studies that have no randomization and studies that dichotomize a decidedly continuous marker don't usually make the podcast. But here I think there are some teaching points. First is the issue of taking a continuous variable and picking a cut point. So here's what you do. Google the words, "the problem with dichotomization of variables," and what pops up is a section of Vanderbilt professor Frank Harrell's wiki page that lists 15 problems with this practice. I won't go into all of them, but here are a couple. Dichotomization on independent variables is completely at odds with making optimal decisions. Here's another thing Harrell says. Categorization assumes that the relationship between the predictor and the response is flat within intervals. Here's another. Researchers seldom agree on the choice of cut point, thus there is severe interpretation problems. And finally, another. Categorization assumes that there is a discontinuity in response as interval boundaries are crossed. So take the specifics of this case. What if the researchers ran the correlation with a BNP of 300 or 350 or 400? You don't know. The second problem with this study, one that journalist Steve Stiles addresses in the news story with his interview of Dr. James Januzzi, is, okay, so what? How does knowing that a BNP is elevated incrementally help a clinician? In the opening line of the news story, which almost always tells the reader the top-line results, Steve Stiles writes, quote, mortality goes up in tandem with admission natriuretic peptide levels in patients with severe COVID-19 pneumonia, but no history of heart failure. I think you could write that same sentence without the word COVID-19 or even without the word pneumonia. You could write the sentence, mortality goes up in tandem with admission natriuretic peptide levels in patients with severe pneumonia, but no history of heart failure. Or mortality goes up in tandem with admission natriuretic peptide levels in patients with severe, insert any disease, but no history of heart failure. This is because BNP is a marker for severe disease. While the simple understanding of BNP goes like this, the level rises when there is increased cardiac chamber wall stretch, an expanded fluid volume, say in heart failure. BNP also rises when clearance goes down, like in renal dysfunction, and also possibly even during a cytokine storm. Diabetes, liver function, obesity, atrial fib, tachycardia can also influence the BNP. Sick people, especially those most severely affected by COVID-19, such as older patients with obesity, hypertension, diabetes, might have an elevated BNP on presentation. Now, when a person comes in with dyspnea of unknown cause, the chest x-ray is inconclusive. A BNP may help. If it's normal, it makes heart failure less likely. If it's 30,000, heart failure is more likely. But in a documented case of infiltrates with a positive COVID test, a BNP probably is going to add little to the supportive care. Dr. Januzzi's quote in the news story, I think, is perfect. He says if the BNP is elevated, it's important for clinicians not to jump at a diagnosis of heart failure. Why? Because doing so might cause you to diurese a patient who needs volume. To any young listeners out there, be careful. Do not ignore biomarkers, but also do use them in the context of the whole clinical scenario. Next topic is polypharmacy in heart failure. Last week, I discussed the major discovery that SGLT2 inhibitor drugs benefit patients with heart failure with or without diabetes. Now, here's the problem. SGLT2 inhibitors are yet another pill a patient has to take, and people are only going to take so many pills. Guideline-directed medical therapy, GDMT, of heart failure already includes 3 drugs, the RAS blockers, the beta blockers, and the mineralocorticoid receptor antagonist like spironolactone. But almost no patients with heart failure with reduced ejection fraction have pure LV dysfunction. Many of these patients have ischemic heart disease or atrial fibrillation or diabetes, hypertension, or a slew of other conditions that are treated with pills. So a group from Weill Cornell Medical College studied the issue of polypharmacy in 558 older patients who were admitted for heart failure. Circulation Heart Failure published the study. Now, the group used baseline data from the REGARD study, which is one of those prospective population-based U.S. cohorts. Some of the baseline characteristics of this study are important. For starters, the median age of patients admitted for heart failure in this study was about 76 years. More than half were greater than age 75, and about 43% were women. So let's just stop there. I just finished making some slides for a talk on legacy prescriptions, and I went back to the original heart failure trials. Did you know that in the beta blocker trials, the average age was 58 to 63, not greater than 75? In these trials, women were 23%, in the MERIT trial, 30% in the carvedilol trials. My point is that before we even get to the polypharmacy issue, is that guideline-directed medical therapy was established in young, mostly male outpatients. But the vast majority of patients we apply guideline-directed medical therapy to are older, often female patients. The vast majority of participants in the study, 84% at admission and 95% at discharge, took greater than 5 medications, and slightly more than half of these patients took greater than 10 medications at discharge. The prevalence of taking greater than 10 medications increased over the study period. Now, the authors did do something nice. They separated the meds out into heart failure meds, non-heart failure but cardiac meds, and non-cardiovascular meds, and a few comments about specific medications. The most common non-heart failure medicine started was aspirin. Now, this is appropriate in patients with a previous history of a cardiac event, like a vascular stroke, not due to atrial fibrillation, an MI, or PCI. But remember, in 2018, there were 3 large trials of aspirin used in primary prevention, and none showed a net benefit. In fact, the ESPRIT trial, which I will link to, specifically studied high-risk elderly patients without prior cardiovascular disease and found a higher mortality on aspirin. In the elderly, to me, it makes no sense to use aspirin unless it is used in patients with clear-cut cardiovascular events. Now, the second most common non-heart failure drug used in this study was a statin. Now, this may sound controversial, but we now have 2 large RCTs in patients with heart failure with reduced ejection fraction. One study was called GC and the other Corona. These studies, which are often ignored, found no reduction in major adverse cardiac outcomes with statin therapy. In GC, 40% of the patients had ischemic causes of heart failure, and in Corona, 60% of patients had a history of MI. Now, the reason these studies do not show a benefit from statins, I think, is pretty clear, and that is competing causes of bad outcomes. Statins do reduce the rate of non-fatal cardiovascular events by a modest amount, but when you are old and you have heart failure, that modest benefit is likely outweighed by other things. The bottom line is that coronary artery disease should not always equal a statin. In the presence of heart failure with reduced ejection fraction, We have 2 large trials that show no benefit. Statins, especially in the elderly and infirmed, offer an excellent opportunity for deprescribing. Another observation was that a common non-heart failure med was potassium replacement. These are big pills that patients hate to swallow. The authors highlight the low use of mineralocorticoid receptor antagonists like spironolactone, and they suggest that adding an MRA may obviate the need for a potassium replacement. And I love that idea. I call spironolactone my secret weapon. This drug, which has RCT level evidence, is underused, at least in my hospital. In sum, polypharmacy is important because patients are only going to take so many pills, and we want to maximize the pills that will have the most benefit. Next topic, cardiac arrest during COVID-19. JAMA Internal Medicine published a research letter from a group at the William Beaumont Hospital in Michigan on clinical outcomes in patients who have cardiac arrest in the hospital who have COVID-19 infection. Now, the background here is important. A recent review found that before the pandemic, only 1 in 4 patients who have cardiac arrest in the hospital survived to discharge. 8 of the 10 of these cases had non-shockable initial rhythms. When the initial rhythm is non-shockable, survival was only 10%. Now keep in mind too that survival to discharge is a low bar. Probably only a fraction of these survivors go on to live independently. Now to the COVID infection. In this single center study, it was about 1,300 patients hospitalized with COVID-19. 4.6, nearly 5% of patients developed in-hospital cardiac arrest and underwent CPR. The research letter described these 54 patients. Only 2 of the 54 had shockable rhythms. PEA and asystole occurred in 52 of 54 patients. Now, return of spontaneous circulation was achieved in 29 patients, about half. Half of these had their code status switched to DNR, while another half were recoded but still died. The survival to discharge was 0 of 54. Most of the patients had comorbid conditions typical of poor outcomes, such as hypertension, diabetes, and obesity. Of course, the first thing to say about this study is that it's single center and observational, but I'm really glad that JAMA Internal Medicine published the study. These are important observations for 4 reasons. First, from a therapy perspective, CPR should be considered a treatment, like a tablet or a procedure. In this study, this treatment failed 100% of the time. Pause on that, 100%. Taking a Bayesian approach, in which previous pre-COVID studies show a 10% survival for non-shockable rhythms, the author's observation of 100% death rate is not at all an outlier. Now, second, from a patient perspective, many patients, when given information on what CPR actually looks like, would choose not to have a 100% ineffective procedure. Third, from a healthcare cost standpoint, CPR and subsequent ICU admission is extremely costly. And again, if we use dollars on futile care, that reduces the resources available for effective interventions. Like I said before, paying people to stay home when sick. Finally, from a safety perspective, CPR in a patient with COVID puts healthcare workers at significant risk. Now, it would be one thing if the procedure had a chance of success. I am no ethicist, but given the dismal success of CPR in this disease, it would seem ethical and moral to not perform this procedure, especially when the initial rhythm is non-shockable. Well, some of you may disagree with this comment. I'm happy to be critiqued. Let me know in the comments section or on Twitter. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, it really helps if you could take the time to give it a rating or a review, and that helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.